A pleasant day to everybody. I am Dr. Timothy Nazareno, a third year radiology resident at the University of Santo Tomas Hospital, and I will be discussing about pulmonary neoplasms. Here are the topics that would be discussed as we breeze through the lecture. First, we define what is a solitary pulmonary nodule. So, a solitary pulmonary nodule is a relatively well defined round or oval pulmonary parenchymal lesion, and its size is equal to or smaller than 3 cm in its widest diameter. Usually, it is surrounded by pulmonary parenchyma and or visceral pleura and is not associated with lymphadenopathy, atelectasis, or pneumonia. We characterize solitary pulmonary nodules based on the following criteria. It includes clinical factors, growth pattern, size, border characteristics, and density. A patient's age may help in the distinction of a solitary pulmonary nodules. In patients younger than 35 years old without any history of smoking or malignancy, the presence of solitary pulmonary nodule may invariably be a granuloma, hamartoma, or an inflammatory lesion. These nodules can be followed with plain radiographs to confirm the benignity of its nature. In patients that are older than 35 years old, particularly with history of cigarette smoking, they present with a significant incidence of malignant solitary pulmonary nodules. 50% of radiographically detected solitary pulmonary nodules in these patients presents as malignancy after thoracotomy. Therefore, an solitary pulmonary nodule in a patient older than 35 years of age should never be followed radiographically without tissue confirmation unless a benign pattern of calcification or the presence of an intralesional fat is identified on imaging, and also there is documented lack of growth over a minimum of 2 years. So there are exceptions to this rule. So a prior history of cigarette smoking, prior lung or head and neck cancer, or asbestos exposure raises the likelihood of a malignant process. We should also take note of patients living in certain places where histoplasmosis and tuberculosis are endemic, because in these cases, a granulomatous process is highly considered. Next is growth pattern. Pulmonary malignancies grow at a relatively predictable rate. The growth rate of a solitary pulmonary nodule is usually expressed as the doubling time. Doubling time is defined as the time it takes for a nodule to double its volume. For a spherical lesion, this corresponds to a 25 increase in its diameter. Although some benign lesions may exhibit a growth rate similar to that of malignant lesions, the absence of growth or an extraordinarily slow or rapid rate of growth of a solid nodule is reliable evidence that a solitary pulmonary nodule is benign. Studies have shown that bronchogenic carcinoma presenting as a solitary pulmonary nodule has a doubling time of approximately 180 days. Therefore, a doubling time of less than 1 month or greater than 2 years reliably characterizes a solid lesion as benign. Examples of lesion exhibiting rapid growth includes metastasis from certain malignancies and infectious causes, whereas lesions exhibiting slow growth includes hamartomas and histoplasmomas. The Fleischner Society has established guidelines for the management and follow-up of small incidental lung nodules on CT scan. If the nodule size is less than or equal 4 millimeters, a low-risk patient does not need to follow up. However, in high-risk patients, follow-up CT scan at 12 months is recommended, and if unchanged, no further follow-up is needed. Nodule sizes greater than 4 millimeters and reaching up to 6 millimeters in patients who are low risk A follow-up CT scan at 12 months is recommended, and if unchanged, no further follow-up is needed. In high-risk patients, initial follow-up CT at 6 to 12 months is recommended, then at 18 to 24 months after if there is no change. If the nodule measures greater than 6 to 8 millimeters in size, a low-risk patient may have an initial follow-up CT at 6 to 12 months, then followed at 18 to 24 months after if there is no change in size. In high-risk patients, initial follow-up CT at 3 to 6 months is highly recommended, followed by 9 to 12 months and 24 months if there is no change in size. If the nodule measures greater than 8 millimeters in size, both types of patient has follow-up CT at around 3, 9, and 24 months with associated dynamic contrast-enhanced CT, PET scan, and/or biopsy is recommended. Next is size of the pulmonary nodule. Although size does not reliably discriminate benign from malignant nodules, the larger the lesion, the greater the likelihood of malignancy. Masses exceeding 4 centimeters in size are usually malignant. However, there are studies which shows that certain malignancies measures less than 2 centimeters in size at the time of diagnosis. In patients with solitary pulmonary nodules screened for lung cancer using low-dose CT, nodules measuring less than 4 millimeters in diameter have a less than 1% likelihood of malignancy. Next is border characteristic of the pulmonary nodule. The appearance of the margin of a solitary pulmonary nodule is a helpful sign in determining the nature of the lesion. A round smooth margin is seen in cases of granuloma or hamartomas. A notch or lobulated contour is also seen in hamartomas. However, the two mentioned borders are also seen in lung malignancies, however they occur infrequently. A spiculated margin is highly suspicious for malignant lesions. The term corona radiata has been used to describe the spiculated appearance of a pulmonary nodule, in which linear densities radiate from the edge of a pulmonary nodule into the adjacent lung. Pathologically, these linear radiations represent reoriented connective tissue septa drawn into the tumor by the cicatrizing nature of many malignant lung tumors. Tumor extension from the nodule or fibrosis and edema of these connective tissue septa may thicken these linear densities. However, it has been shown that speculation is not specific for malignancy because benign processes that produce cicatrization can have an identical appearance. Another characteristics at the border of a pulmonary nodule which can help identify the nature of the lesion is the presence of small satellite nodules. Its presence around the periphery of a dominant nodule is strongly suggestive of a benign disease, particularly granulomatous infection. Next is pulmonary nodule density. The internal density of a solitary pulmonary nodule is probably the single most important factor in characterizing the lesion as benign or indeterminate. Multiple patterns of calcification exist that reliably indicate the benignity of a solitary pulmonary nodules, and these patterns can be seen in chest radiographs and in CT scan. Benign patterns of calcification include complete or central calcification, which is seen in heel granuloma from tuberculosis or histoplasmosis, concentric or laminated calcification, which is also seen in granulomas, popcorn calcification, which is seen in hamartomas. 10% of malignant nodules contain calcification on CT scan. Malignant pulmonary neoplasm may demonstrate small microscopic foci of calcification, particularly the adenocarcinoma type. Identification of fat within a solitary pulmonary nodule is diagnostic of a pulmonary hamartoma. Next, we will discuss lesions that presents as solitary pulmonary nodules. First is pulmonary hamartoma. Pulmonary hamartoma is a misnomer and actually reflects a benign neoplasm composed of an abnormal arrangement of mesenchymal and epithelial cells found in normal lung. Histologically, these tumors contains cartilages, connective tissues, fat, and seromucous glands. Calcification can be seen in 30% of cases. These tumors are seen in the 4th and 5th decades of life and represents 5% of all the solitary pulmonary nodules. These lesions usually present as an incidental finding. However, a confident diagnosis of hamartoma can be made when using high-resolution CT scan showing a nodule smaller than 2.5 centimeters in diameter and exhibits a smooth or lobulated contour and contains focal fat. The presence of popcorn calcification is also diagnostic. A low-grade B-cell non-Hodgkin's lymphoma may present as a solitary pulmonary nodule or a focal airspace opacity. Diagnosis of non-Hodgkin's lymphoma is made by immunohistochemistry and flow cytometry of resected specimens or aspirated cells obtained from biopsy. Hemangiopericytoma is a connective tissue tumor that arises within the pericyte, a cell associated with the arteriolar and capillary endothelium. On chest radiographs, these lesions are seen as solitary pulmonary nodules and are indistinguishable from bronchogenic carcinoma. Lipomas are rare intrapulmonary lesions that arises more commonly within the tracheobronchial tree to produce atelectasis. The demonstration of fat attenuation on CT scan is diagnostic. Lipoid pneumonia results from aspiration of mineral oils ingested by elderly patients to treat constipation. Patients with gastroesophageal reflux or disordered swallowing mechanism are at particular risk of developing this type of pneumonia. Radiographically, a focal area of airspace opacification is seen or a solid mass in the lower lobes is appreciated. Bronchogenic cysts are fluid-filled structures of the lung and may produce a solitary pulmonary nodule. 90% of these lesions are found at the medial mediastinum. Superinfection of a bronchogenic cyst can occur and may appear on radiographs or in CT as an air fluid level within an air-filled structure. So let us now proceed with the discussion of bronchogenic carcinoma. Bronchogenic carcinoma is a malignant neoplasm that arises from the bronchial or alveolar epithelium. 99% of malignant epithelial neoplasms of the lung arises from the bronchi or lung, whereas fewer than 0.5% arise from the trachea. Bronchogenic carcinoma is divided into four main histologic subtypes on the basis of their gross and microscopic features. This includes adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. Adenocarcinoma is the most common type of lung cancer and accounts about one-third of all cases of bronchogenic carcinomas. This type of cancer is frequently seen in non-smokers. Usually, the location of this malignancy is at the lung periphery. However, in one-fourth of the cases, these are seen as central lung lesions. Adenocarcinoma arises in the bronchiolar and alveolar epithelium with associated irregular and spiculated margins. Fibrosis is common in this type of cancers. A subtype of adenocarcinoma, which is called adenocarcinoma in situ, which is previously called bronchoalveolar cell carcinoma, has a unique pathological feature. This tumor is characterized by growth along pre-existing bronchiolar and alveolar walls without invasion or distortion of alveolar walls, blood vessels, or lymphatics. Next is squamous cell carcinoma and is the second most common subtype of bronchogenic carcinoma and accounts for approximately one-fourth of all cases. This tumor arises centrally within a lobar or segmental bronchus. These tumors may grow as a polypoid mass that grow into the bronchial lumen while simultaneously invading the adjacent bronchial wall. The central location and endobronchial component of this tumor accounts for the presenting symptoms of cough and hemoptysis. The presence of central necrosis and cavitation is commonly seen in this type of bronchogenic carcinoma. Small cell carcinoma accounts for 25% of bronchogenic carcinomas, and this tumor arises centrally within the main or lobar bronchi. These tumors are the most malignant neoplasms arising from bronchial neuroendocrine cells and are alternatively referred to as Kolchitsky cell cancers. This type of tumor exhibits a small endobronchial component invading the bronchial wall and peribronchial tissues early in the course of the disease. This results to a hilar or mediastinal mass with extrinsic bronchial compression and obstruction. Invasion of the submucosal and peribronchial lymphatics lead to local lymph node enlargement. Large cell carcinoma accounts for 15% of bronchogenic carcinomas. This is diagnosed when a non-small cell bronchogenic carcinoma lacks the histologic characteristics of either squamous cell carcinoma or adenocarcinoma. Histologically, this appears as large cells within abundant cytoplasm and prominent nucleoli. This tumor tends to arise peripherally as a solitary mass and is often large at the time of presentation. The following are risk factors that increases the probability of developing bronchogenic carcinoma. Cigarette smoking is by far the leading cause of lung cancer with approximately 87% of cases attributed to smoking. Patients with history of cigarette smoking has a 10 to 30-fold increase in the incidence of bronchogenic carcinoma compared to non-smokers. Prolonged asbestos exposure can also cause increased incidence of developing bronchogenic carcinomas. Previous Hodgkin's lymphoma, radon exposure, viral infection, and interstitial or localized lung fibrosis can also increase the probability of developing lung cancer. We now proceed with the radiographic findings of bronchogenic carcinoma. The appearance of bronchogenic carcinoma depends on the subtype of cancer and the stage of disease at the time of diagnosis. The two most common findings include a solitary pulmonary nodule measuring between 2 millimeters up to 3 centimeters, or a mass which measures 3 centimeters or larger in size, and a hilar mass with or without bronchial obstruction. Because squamous cell carcinoma and small cell carcinoma arises from the central bronchi, the majority of these types of bronchogenic carcinoma produces a hilar mass. The hilar mass represents either the extraluminal portion of the bronchial tumor or hilar lymph node enlargement from metastatic disease. Extension of the hilar lesion into the mediastinum or the presence of mediastinal nodal metastasis can produce a smooth or lobulated mediastinal mass. Marked mediastinal nodal enlargement producing a lobulated mediastinal contour is characteristic of small cell carcinoma. Obstruction of the bronchial lumen by the endobronchial component of a tumor can result in several different radiographic findings. Obstruction either leads to resorptive atelectasis or obstructive pneumonitis. Resorptive atelectasis is recognized by the classic findings of lobar or whole lung collapse, whereas obstructive pneumonitis results in minimal or no atelectasis or occasionally an increase in the volume of the affected portion of the lung. An abnormal increase in lobar or whole lung volume is recognized radiographically by a bulging interlobar fissure marginating the obstructed lobe or by mediastinal shift, respectively, and is termed drowned lung. Occasionally, the mass producing the lobar atelectasis creates a central convexity in the normally concave contour of the collapsed lobe, producing the S sign of Golden. Most commonly, the opacity of the obstructed lung obscures the underlying central lesion. The lung with obstructive pneumonitis is not infected, but rather shows a chronic inflammatory infiltrate and alveolar filling with lipid-laden macrophages. The latter finding accounts for the descriptive terms golden or endogenous lipoid pneumonia. Other findings suggestive of atelectasis includes obliteration of the main and proximal bronchi, middle and lower lobe atelectasis, and presence of mucocele. The presence of cavitation is uncommon, however, it is most commonly seen in the squamous cell subtype. Cavitating neoplasms exhibit thicker walls and has a more nodular appearance when compared to inflammatory lesions. Lung malignancy can also present with bubbly lucencies and presence of air bronchograms. These radiographic findings are usually seen in the adenocarcinoma subtype, particularly in bronchoalveolar carcinomas. The presence of a spiculated margin or corona radiata, as well as intralesional eccentric calcification seen within the tumor, increases the probability that these lesions are malignant in nature. Pancreas or superior sulcus tumor is a peripheral neoplasm arising in the portion of the lung apex. Any cell type can develop Pancreas tumor. However, the majority of these lesions are squamous cell carcinomas or adenocarcinomas. The presenting symptoms are related to invasion of the adjacent structures. Arm pain and muscular atrophy can be secondary to brachial plexus involvement, Horner syndrome from involvement of the sympathetic chain, and shoulder pain from chest wall invasion. In chest radiograph, the presence of apical thickness exceeding 5 mm, asymmetry of the apical opacities of more than 5 mm, enlargement on serial radiographs, or evidence of rib destruction should prompt further evaluation with helical CT scan or MRI. Airspace opacification is a common finding in bronchoalveolar carcinoma because malignant cells grow along the pre-existing parenchymal lattice while producing large amounts of mucus. In diffuse forms of bronchoalveolar carcinoma, a so-called CT angiogram sign is seen in consolidated areas. This is identification of bronchial vessels within an airless portion of the lung on contrast-enhanced CT. Superior vena cava syndrome results from obstruction of the superior vena cava from compression or invasion by a mediastinal tumor, particularly small cell carcinoma or lymphoma. Lung cancer is the most common cause of superior vena cava syndrome. A malignant pleural effusion is an exudative fluid collection in a patient with proven malignancy that shows malignant cytology on thoracentesis or tumor on pleural biopsy. The presence of malignant pleural effusion indicates a poor prognosis in a patient with bronchogenic carcinoma. In certain cases of bronchogenic carcinoma, we could also appreciate presence of chest wall invasion. Lymphangitic carcinomatosis represents invasion of the lymphatic channels of the lung by tumor. Invasion of lymphatics or neoplastic involvement of hilar and mediastinal nodes leads to retrograde lymphatic flow with dilatation of lymphatic channels, interstitial deposits of tumor, and fibrosis. Radiographically, the typical findings are linear and reticulonodular opacities with peribronchial coughing and subpleural edema or pleural effusion. Lymphangitic spread to hilar and mediastinal lymph nodes produces unilateral lymph node enlargement with interstitial opacities, whereas hematogenous dissemination of tumor to the pulmonary capillaries with secondary lymphatic invasion leads to bilateral interstitial abnormalities. Unilateral or asymmetric involvement of the lungs by lymphangitic tumors suggests lung cancer rather than an extrapulmonary site. Let us now proceed with the radiologic staging of lung cancer. The primary role of the radiologist in imaging the patient with lung cancer is to determine the anatomic extent or stage of the tumor. This has prognostic importance and determines the resectability of the tumor. The staging of non-small cell bronchogenic carcinoma is based on the extent of the primary tumor, the presence of nodal involvement, and evidence of metastasis. By using this TNM classification, bronchogenic carcinoma is divided into four stages. T classification determines the extent and size of the tumor. If the tumor is classified as T0, there is no evidence of primary tumor. If the tumor is classified as Tx, There is presence of malignant cells in sputum without identifiable tumor. A tumor is classified as T1 if its size is less than that or equal to 3 centimeters. If its size is up to 2 centimeters, it is classified as T1A, and if its size is greater than 2 centimeters, reaching up to less than 3 centimeters, it is categorized as T1B. A tumor is classified as T2 if its size ranges from greater than 3 centimeters to less than or equal to 7 centimeters. It is also tumors of any size that invades the visceral pleura, involves the main bronchus but spares the carina, shows atelectasis or obstructive pneumonitis that extends to the hilum. If the size of the tumor is greater than 3 centimeters and up to less than or equal that of 5 centimeters, it is categorized as T2A, and it is categorized as T2B if its size is greater than 5 but less than or equal 7 centimeters. T3 tumors are lesions with sizes greater than 7 centimeters, and these tumors may exhibit invasion of the chest wall, pericardium, phrenic nerve, and also shows one or more satellite nodules in the same lung lobe. T4 tumors are lesions of any sizes that exhibits invasion of the mediastinal fat and mediastinal structures, invasion of the diaphragm, involves the carina, and shows one or more satellite nodules in another lobe on the ipsilateral side. Before we begin with the discussion of the nodal staging of bronchogenic carcinoma, I will briefly lecture about the thoracic lymph node stations. Thoracic lymph nodes are divided into 14 stations as defined by the International Association for the Study of Lung Cancer, principally in the context of oncologic staging. For the purpose of prognostication, the stations are grouped into 7 zones. The first zone is supraclavicular zone, which includes the low cervical, supraclavicular, and sternal notch nodes. The next is superior mediastinal nodes, which includes the upper paratracheal, prevascular, and prevertebral lymph nodes. And next is the inferior mediastinal nodes, which includes the lower paratracheal lymph nodes. Next is the aortic zone, which includes station 5, the subaortic lymph nodes, and station 6, which is the para-aortic lymph nodes, followed by the subcarinal zone, which includes the subcarinal lymph nodes. Next is the inferior mediastinal nodes, which includes the paraesophageal and pulmonary ligament lymph nodes. And lastly are the pulmonary lymph nodes, which are stations 10 to 14. For the nodal staging of bronchogenic carcinoma, N1 lymph nodes are enlarged lymph nodes at the ipsilateral pulmonary and hilar nodes. N2 nodes represents enlarged ipsilateral mediastinal or subcarinal lymph nodes, while N3 lymph nodes are enlarged contralateral, mediastinal, and hilar lymphadenopathy or presence of enlarged lymph nodes at the scalene or supraclavicular region. For the metastatic staging of bronchogenic carcinoma, if the lesion is categorized under M0, then there is no distant metastasis noted. If the lesion is categorized under M1, then distant metastasis is present. Under M1A or regional metastatic disease, there is presence of malignant pleural or pericardial effusion or nodules, as well as contralateral or bilateral pulmonary nodules. In M1B, there is solitary or multiple extrathoracic metastasis, either in a single organ or in multiple organs. Here is a summary of the T, N, and M staging of bronchogenic carcinoma. A bronchogenic carcinoma is categorized as 1A with a T-score of T1A or B with no nodal involvement or metastasis. It is under 1B if the T-score is T2A with no nodal or metastasis. It is under 2A with the following TNM score. It can either be a lesion presenting with a size of T1A or B with N1 nodal involvement but with no metastasis. It can also present with a lesion with a size of T2A with N1 nodal involvement with no metastasis. It could also be a lesion with a size of T2B with no nodal involvement and no metastasis as well. A lesion is under 2B if the T-score is T2A with N1 nodal involvement and no metastasis. T3 in size with no nodal involvement or metastasis appreciated. A lesion is classified as 3A with the following TNM grading. Its size can reach either T1 or T2 with N2 nodal involvement with no metastasis. The size could also reach up to T3 with N1 or N2 nodal involvement still with no metastasis. And lastly, the size can reach up to T4 with no or N1 nodal involvement but with no metastasis. A lesion is under 3B if the size reaches T4 with N2 nodal involvement with no metastasis. It can be any tumor of any size with N3 nodal involvement but still with no metastasis. And lastly, a lesion is categorized as stage 4 if the tumor is of any size and with any nodal involvement, however presents with any classification of metastasis. Next, we will tackle the metastatic disease to the thorax. The spread of extrapulmonary neoplasm to the lung may occur by direct invasion of the pulmonary parenchyma or as a result of hematogenous dissemination, with the latter mechanism much more commonly seen. In rare instances, a tumor can disseminate throughout the lungs via tracheobronchial tree and is usually seen in cases of laryngotracheal papillomatosis and some cases of bronchoalveolar carcinoma. Transpleural spread of tumor can be seen in cases of invasive thymoma. Direct invasion of the lung may occur with mediastinal, pleural, or chest wall malignancies. The most common mediastinal malignancies associated in lung invasion are esophageal carcinoma, lymphoma, and malignant germ cell tumors, or any malignancy metastasizing to the mediastinal or hilar lymph nodes. Malignant mesothelioma and metastasis to the pleura or chest wall can extend through the pleura to invade the adjacent lung. Hematogenous metastasis to the lung may be seen with any tumor that gains access to the superior and inferior vena cava or thoracic duct because the pulmonary artery is the final common pathway for these channels. Pulmonary nodules are the most common manifestation of hematogenous metastasis to the lung. They are most commonly seen in carcinomas of the breast, kidney, thyroid, colon, uterus, head, and neck. Although most patients have multiple nodules, metastasis can present as solitary pulmonary nodules. These kinds of nodules, which are related to metastasis, are typically smooth in contour, whereas primary bronchogenic tumors tend to be lobulated or spiculated in appearance. The likelihood that a solitary pulmonary nodule represents a solitary metastasis in a patient with a synchronous extrathoracic malignancy is slightly less than 50%, whereas solitary pulmonary nodules in patients with prior malignancies are almost always primary bronchogenic tumors or granulomas. Carcinomas of the rectosigmoid colon, osteogenic sarcoma, renal cell carcinoma, and melanoma are most likely to result in solitary pulmonary metastasis. Nodular pulmonary metastases are usually smooth or lobulated lesions that are found in greater numbers in the peripheral portion of the lower lobes because of the greater pulmonary blood flow to these regions. Helical CT scan is the modality of choice for the evaluation of pulmonary metastasis because it is considerably more sensitive than plain radiographs, conventional whole lung tomography, and incremental CT in detecting lung nodules. There are no characteristic features of nodular metastasis that allow distinction among different primary neoplasms. Similarly, the distinction between metastasis and granulomas is usually impossible. The diagnosis of nodular pulmonary metastasis is usually presumptive. It is based on the demonstration of multiple pulmonary nodules in a patient with a known malignancy that has propensity for lung metastasis who lacks evidence of a granulomatous process. In some patients, particularly those with solitary pulmonary nodules and no evidence of additional sites of metastasis or those with a history of a prior localized malignancy, a biopsy of the nodule should be performed. We now proceed with the last topic to be discussed, which is non-epithelial parenchymal malignancies and neoplastic-like conditions. So first on our list is lymphoma. Parenchymal involvement in Hodgkin disease is 2 to 3 times more common than in non-Hodgkin's lymphoma. Parenchymal abnormalities in Hodgkin's lymphoma usually produce linear and coarse reticulonodular opacities that extend directly into the lung from enlarged hilar lymph nodes. Atelectasis in Hodgkin disease is rarely caused by extrinsic nodal compression of the bronchi, but rather develops from an obstructing endobronchial tumor. While parenchymal involvement in Hodgkin disease does not occur in the absence of hilar and mediastinal nodal disease, non-Hodgkin lymphoma may involve the parenchyma without concomitant nodal disease in up to 50% of cases. Nodular lymphoid hyperplasia is previously termed pseudolymphoma and is used to describe a localized non-neoplastic reactive proliferation of lymphocytes in the lung. Histologically, the distinction from well-differentiated lymphoma may be difficult. The demonstration of a polyclonal population of lymphocytes with a multiple germinal centers and the absence of lymph node enlargement are necessary for the diagnosis. These kinds of disease have good prognosis, although it may develop into a lymphoma in patients with Sjogren's syndrome. Lymphocytic interstitial pneumonitis or diffuse lymphoid hyperplasia is an infiltration of the pulmonary interstitium by mature lymphocytes that is histologically indistinguishable from nodular lymphoid hyperplasia. Radiographically, a predominantly lower lobe reticulonodular and linear pattern of disease is seen. CT findings include diffuse ground glass opacity, poorly defined centrilobular nodules, thin-walled cysts, and lymph node enlargement. Post-transplant lymphoproliferative disorders represent a spectrum of diseases ranging from benign polyclonal lymphoid proliferation to aggressive non-Hodgkin's lymphoma, which develop in a small percentage of transplant patients, with lung transplant recipients most commonly affected. Infection with Epstein-Barr virus is responsible for most cases. The most common imaging finding is that of solitary or multiple sharply marginated nodules or masses. Lymphomatoid granulomatosis was originally thought to represent a distinct histologic entity but has recently been reclassified as a form of pulmonary lymphoma. Histologically, there are multiple round nodules containing lymphocytes that infiltrate small vessels to produce an obliterative vasculitis. These findings are similar to Wegener granulomatosis, although well-formed granulomas are rare in lymphomatoid granulomatosis. Radiographically, there are multiple nodular opacities with a lower lobe predilection. Cavitation is common and results from ischemic necrosis. For leukemia, leukemic involvement of the lung is found in approximately one-third of patients at autopsy. Clinical or radiographic evidence of parenchymal infiltration is uncommon during life. Majority of pulmonary disease associated with leukemic patients are caused by pneumonia due to immunosuppression, edema from cardiac disease, or hemorrhage due to thrombocytopenia. Parenchymal involvement in leukemia usually takes the form of interstitial infiltration by leukemic cells with resultant peribronchial coughing and reticulonodular opacities on chest radiograph. An unusual pulmonary manifestation of leukemia is pulmonary leukostasis, which is seen in acute leukemia or those in blast crisis. In this condition, the white cell blasts clump within the pulmonary microvasculature to produce dyspnea. Approximately half of affected patients have normal radiographs, whereas the remainder demonstrate a diffuse reticulonodular pattern of disease. Kaposi sarcoma of the lung is a common complication of AIDS. Pulmonary involvement almost invariably follows skin, oropharyngeal, and visceral involvement. This disease produces small to medium poorly marginated nodular and coarse linear opacities that extend from the hilum into the midlung and lower lung. CT shows the typical peribronchovascular location of the opacities and may demonstrate air bronchograms traversing mass-like areas of confluent disease. A bloody pleural effusion is present in up to 50% of cases. This is attributed to the lesions within the subpleural interstitium of the lung. Important diagnostic features of pulmonary Kaposi sarcoma are the slow rate of progression of disease and the absence of fever or pulmonary symptoms despite extensive parenchymal disease. Pulmonary blastoma is a rare malignant tumor affecting children and young adults. The tumor comprises of both mesenchymal and glandular elements of the lung, with an appearance simulating that of a fetal lung at 10 to 16 weeks age of gestation. Tumors that are composed of glandular elements are called fetal adenocarcinomas, while those purely of malignant mesenchymal alone are referred to as cystic and pleuropulmonary blastomas of childhood. Those with mixed elements are called biphasic blastomas. Prognosis is poor because many lesions have metastasized at the time of diagnosis. That ends my discussion. Thank you for listening.